Okay. So hi everyone. My name is Talah Nammor. I'm a fourth year medical student, and I'm here today to give you the cardiac muscle excitation and contraction. I'm pretty sure this lecture seems challenging, but I promise you it's gonna be easy after the session, inshallah yani. So those slides are literally Dr. Abdul Jabbar's slides. I didn't do my own slides because I thought I wanted to guide you on how to approach Dr. Abdul Jabbar's slides because I know sometimes they might be challenging. Okay, so we start here with a review of the action potential. Honestly, I'm not going to go into the details of the review of action potential because you're going to have a whole pulse session about the action potential. It's going to be uploaded soon, and it's by Khaled Jamil. He's an amazing how tutor. So I encourage you guys to watch that. Let's directly dive into the cardiac muscle. So the cardiac muscle, an important thing to know is that we have two different kinds of cells. We have the contractile cells, okay, and then we have the autorhythmic cells or the pacemakers. Now, what's the difference between the contractile cells with pacemakers? The pacemakers are the cells that will produce the electricity for the heart. And we know that for every contraction, we need electricity, or in other names, action potential. So basically, the electricity will be formed by these pacemakers. So they will have a different physiology. They're not going to have the same physiology that contractile cells will have. And I'm pretty sure you guys will cover this later in CVP. But for now, you just have to know that basically they are the bus, like the big bus. They send electrical signals for the contractile cells or the cells that make up the whole heart, okay, and that actually contract to contract, okay? So they are usually there for sending signals. They're smaller and there are fewer fibers than the contractile fibers, and they do not have organized sarcomeres. So what are sarcomeres? Wait, sorry. Do you see the photo اللي موجود that is literally in the middle of the slide? So basically okay, wait, I can annotate, I think. Let me try. Oh, wait. Okay. I think we can edit this away, okay, guys? Just 1 second because it's hard to explain without annotating. See my screen? I think you can see the screen, right? Can you guys confirm?
Yes, we can see the screen.
Okay, perfect. Okay, so I was talking about the sarcomeres. So the sarcomeres are the things you see here, okay? Like this whole entity. So this whole thing is a sarcomere, all right? And basically, you have to know that the pacemakers or the autorhythmic cells, they are not organized in sarcomeres, but they are formed of fibrils and myofibrils and so on, okay? So we finished talking about the pacemakers or the electricity producers and the big boss that controls everything. Now we're going to talk about the normal people or the normal cells, which are the contractile cells. So the contractile cells, they're striated fibers and they're organized into sarcomeres. What does that mean? So basically you see here, guys, now we have different fibers, okay? So basically, we have a lot of these cells, they will join together and they'll form the fibers, and then all together they'll form the muscle or the sarcomere here, okay? And then the whole heart is made up of many different sarcomeres that are attached together. And they're attached together by something called intercalated discs. And this is important to know, what is an intercalated disc? Intercalated disc, it just joins two different sarcomeres, and you guys can see it right here, okay? And why is this important? It's just important to know that the muscles, all the muscle cells of the heart are connected together. And because they're all connected together, the electricity or the impulse is going to go through all of them, okay? So these these intercalated discs are between two sarcomeres to allow the electricity to rush through it. So it's going to rush like this throughout the heart. Okay? So this is everything you have to know from this slide, and the idea of basically that the cardiac electrophysiology, or basically the electricity that is formed by the pacemakers or the electrical cells, or like, I'm calling them electrical cells because they produce electricity. So they are responsible for the contraction of the heart. And then the contraction of the heart is the thing that is going to cause the blood to move through the heart, and it will result in the cardiac output. So this sentence in here, it might seem like kind of like cardiac output, cardiac electrophysiology, contraction of the, like, it's gonna have like a lot of words, but it simply means that we have pacemaker cells, they produce energy, they produce electricity, and this electricity is going to cause the contractile cells to contract, and the contraction is going to cause the movement of the blood, which will then basically like carry, how blood carries oxygen and nutrients and whatever, so it's going to meet the metabolic demands of the body. Okay, this slide is pretty easy. It's just stuff like I think that you guys get. And then in here, they're talking about the electrical conduction in the heart. So what we have to identify is basically that we have something called the sinoatrial node, AV node, and the Purkinje fibers, all right? Now, those nodes and Purkinje fibers, they are made entirely of pacemaker cells, all right? So they are the ones that conduct the electricity of the heart. And if you look in here, you can literally see the system. This is the SA node, okay? And then it's connected to the AV node. And then the AV node will have basically, this is called the bundle, and then it will go into the different bundle branches, and then it will form the Purkinje fibers. Now, this is what basically conducts the electricity of the heart. And what Dr. Abdul Jabbar is trying to say in here, that the SA node is like the actual big boss of the heart, because it is the one that sets the heartbeats. So I'm pretty sure you guys know what is the range of the normal heartbeats. Can anyone just tell me? You can just write it in the chat if you want. And I think Ghazi can double check.
70 to 90.
It's close. It's usually from 60 to 100. And this range is literally determined by the sinoatrial node, or the SA node. So the SA node is the big boss, and it's gonna tell the heart, okay, you have to beat 70 beats per hour, or 60, or like any number between this range, okay? So it will release the electricity to the AV node, okay? It's going to travel all the way here. And then it will and then the AV node is gonna send the electricity all the way to the Purkinje fibers and so on. But what is really important is to know the conduction speed. So the conduction speed of the AV node is slower than the SA node. So there is like a little bit of delay. And I'm pretty sure you're gonna ask why. Well, this delay will help the heart. So you know how basically the blood enters from here, and then it fills up the atrium, okay? And then it has to go into the ventricle. So how will it go into the ventricle? By basically contraction. So the atrium has to contract. What will tell the atrium to contract? The SA node. So the SA node is gonna send signals, okay, or electrical impulses to all the cells beside it in here. And remember the intercalated discs that we talked about here? So because we have intercalated discs between the different cardiac cells, or the different contractile cells, the impulse is gonna travel fast all over. So 1 second, let me erase here again. So the SA node here is gonna release an impulse, or we can just draw here, it's better. So the SA node is gonna release like an electrical impulse, and it's gonna go to the cells in here. So the cells in the atrium, what will they do? They will contract, because the big boss is saying, oh, you guys have to contract. And you can see here in the photo that the purple is the way that what is it called? The electricity travels. So it will cause the atrium to initiate the contraction. And at the same time, it will travel from here from here, from the SA node, all the way through these electrical bundles to the AV node, all right? But the AV node is a bit slower than the SA node. So it won't directly send it in here. It will take a little bit more time. And if you think of it, physiologically, that's amazing. Why? Because it will allow the heart to have enough time to basically for the atrium to contract and pull the blood, like to push all the blood into the ventricles. So technically, this delay allows the atrium to fill the ventricle. And this is even better for us because we're going to have enough time for the blood to flow from the atria to the ventricle. And then once the ventricle is filled with blood, so the impulse is going to go all the way to the Purkinje fibers and so on. And then it will cause basically the ventricles to contract, and it's a cycle. So this cycle, you're going to take it in more and more details in CBP. But for now, you just have to know that we have an SA node, we have an AV node, and we have a Purkinje fiber. Now, the SA node is the big boss. It considers like, okay, it says we have to beat, let's say 70 beats per minute. So it's the one that decides the heartbeat, okay, or the heart rate. And it does that by sending electrical impulses. The second important point you have to know that the AV node conducts electricity at a slower rate. And this slower rate allows the ventricle to fill up blood from the atrium. Okay? This is like the two most important things, and Dr. Abdul Jabbar mentioned them here, like the AV node delay. And another thing, basically, if you look at the way that electricity goes, it goes from the base of the heart all the way to the apex. And that's how basically, so if you think of it, the atriums are all the way up or at the base of the heart. So if we want the blood to go from the atrium to the ventricle, we would want the electrical impulse to go that way. So basically the electricity is literally going all the way from the atrium or at the base of the heart, all the way down to the apex of the heart. And this is what makes the whole contraction, relaxation, and the heartbeat go on. Okay? In case we have later on in third year, you're gonna take different diseases where sometimes, okay, the SA node is no longer functioning for whatever reason, okay? So the SA node is not capable of producing electricity at the at the certain rate, which is basically 60 to 100, depends, okay? But for your exam's sake, just memorize 70, okay? The normal range is from 60 to 100, but for your exam, just because Dr. Abdul Jabbar wrote 70 here, just memorize the 70, okay? So sometimes, as I'm saying, the SA node does not work. So the next you know how basically in a hierarchy you have if someone dies, another person takes over. So the next person to take over is usually the AV node, and the AV node basically pumps blood at a rate of 50 beats per minute. So in case we don't have in case the sinoatrial node fails to work, the AV node will take over and it will beat. It will cause the heart to beat at a rate of 50 beats per minute. And if the AV node fails, and we have a lot of different disorders that you will not take now, you'll take later, but it's interesting. So if the AV node no longer works, okay, the Purkinje fibers will release electrical impulses, but they will be at 25 beats per minute. Okay, and when I say that they will release electrical impulses at 25 beats per minute, I mean for within a minute, they're going to release 25 impulses to the contractile cells to contract. Okay, so it's not it's just one impulse and it's just going to be oh yeah, beat 25 minutes. No, it's just going to keep on throughout the minute sending impulses, allowing the heart to beat. All right? Do you guys understand? Yeah, sure.
What if it's the opposite? What if the heartbeat is at normal rate for that person's 120? Then what is happening? Or can it mean that more than one is working at the same time?
Okay, I was just going to cover that. So basically, it's important to note that if the SA node is working normally and there's no any defects, it's going to be the heartbeat is going to be from 60 to 100. So it's like a war between who's the strongest, and SA node always win. So basically, it's SA node, AV node, Purkinje fibers. So if SA node is like working and it's alive, it's gonna always be from 60 to 100. And then if it stops working, it's AV node. And then if AV node stops working, Purkinje fiber is gonna work. You get me? So it's like whoever is the strongest and is available is gonna set the rules. You get me? But in like the cases you're asking, it's like there's so many different diseases that cause increased heart rate, and it's not within the scope of this lecture. I'm pretty sure in CVP you might get an idea of why that happens, or you might wait till third year and you'll figure it out. But for now, don't go into a lot of details. Just if you know this basic for this exam, it will be okay. And if you're really interested, I can answer you after this lecture, okay?
Okay, thank you.
Do we have any questions till now? Or is this 2 slides clear? Is these 2? Clear? Move on. Okay.
Yes, move on. Nothing with the chat.
Okay, perfect. So to explain this, okay, I'm going to use this, like the image alone, without whatever the doctor writes here. Or it's literally the same thing, but it's easier to like explain on an image. But before I go there, I wanted to say that the action potential of the contractile cells is different than the action potential of the autorhythmic cells or the pacemaker cells, or what I'm calling the electrical cells. And in this lecture, the doctor does not cover the like electrical cells action potential, and you're gonna cover it in CVP. But for now, I want you to know that the action potential cycle that I'm going to explain right now, it's only for the contractile cells of the heart, all right? Or wait, no, it's for the autorhythmic cells for the heart, sorry. Or it's the same. No, it's not. Never mind, guys, never mind what I'm saying. Anyways, for now, let me explain this. I'll double check and I'll tell you. But for now, this is, I'm pretty sure this is only for the contractile cells, okay? The autorhythmic cells, you're gonna have an action potential, like the action potential slide is different, like the curve. But you're not gonna cover it now, you'll cover it later, okay? That's all I need you to know. Perfect? I'm sorry if it was
Sorry, can you just repeat? So this is the action potential for
yeah.
what
So
exactly?
this is the action potential of the contractile cell of the heart, okay? It's not
perfect.
the pacemaker cell. The pacemaker cell, it has its own action potential, and you're gonna cover this later on in CVP, I think, which is literally the next block. But for now, let's go into the action potential of the contractile cell. So we all know that basically we have a resting membrane potential. And the resting membrane potential, or what we see here as 4, okay? The resting membrane potential is usually maintained by the like movement of the potassium, okay? And I want you guys to like focus with me here because I want to relate this, like this slide with this. So what happens is that at the resting membrane potential, which is 4, the potassium is at this level where it's like a straight line, okay? So the 4 here, I'll show you, this and this corresponds to this and this, okay? Okay, so we all know that to basically have a contraction, we need to have basically impulse, or this is like this is the electricity the pacemaker releases. So it will release the like action, like the what is it called? The impulse, the electrical impulse, like, oh, you have to contract now. So this will translate into the resting membrane potential, okay? So the sodium channels in here, okay? The sodium channels in here, they will respond, they're voltage gated. And by voltage, we mean that they are sensitive to electricity. So once we have an electrical impulse, they will directly open, okay? So this electrical impulse has to be at a certain threshold, okay? And the threshold is usually at like negative 55. So once we reach the negative 55, okay, which basically like the electricity is gonna come and it's gonna cause the resting membrane potential to not be resting anymore. Like it's not gonna rest anymore. It's not gonna be at the -90 that you see right here. It's gonna increase. And then it will reach -55. And once it reaches -55, the voltage gated sodium channels are going to open. Okay? They're gonna open so fast. So a lot of sodium are going to gush in. Like once it opens, sodium cannot wait and it goes all the way in. And you can see here that basically the inward movement of like sodium is so fast, and it's so like, how do I know it's so fast? Because you can see how like it goes on for like a very minimal time. So it
Talah.
So let's go. Okay. So we said that the resting membrane potential is controlled by potassium. And here is like at 4, it's stable and we don't have any electrical impulse. Once the pacemakers, they send us the electricity, they send the electrical impulse, it will cause the threshold to increase. And then once it reaches -55, somewhere here, the voltage gated sodium channels are going to open. It's like imagine, okay, this is the gate, okay? This is the gate, and this is like the outside of the cell, and this is inside of the cell. And in here we have like billions of sodium cells, okay? So once this opens, or just like, okay, never mind. But we have millions of cells. And once the gate open, they're just gonna like rush in so fast. So we're gonna have like a lot of sodium in. And because sodium is positively charged, it's going to increase the charge of the cell, because we're gonna have a lot of positive cells here. It will become more positively charged, right? So that's why you see this peak, like this crazy peak all the way up. But once it reaches +20, the voltage gated channels, they're just like, okay, sodium in here equals sodium in here, or it's like closed, we're just bored, okay, it's not doing anything anymore, it's not fun anymore. Like just think of it as a game. Once you have it, you're not gonna feel like it's fun anymore. So they're just gonna close or become inactivated, okay? Now, this word inactivated is important. I'm going to discuss why later on, okay? Yes, do you have a question?
I have a question. Yeah, when we were taking the lecture, the doctor said that they close at 35, and then in the slide it shows 20.
Listen, the numbers, it depends on where did he get the picture from. Just stick to whatever numbers the doctors say. Because basically it's usually a range. Like let's say it's from +20 to 35, blah blah blah. It doesn't really matter. Just stick to whatever the doctor said in the lecture. Now in this image it shows +20, but maybe in another book it shows +35. Usually it's just like a range, you know? So it's not like not 100% like the thing you take. It's just a range. Maybe it's from +20 to +35, but always stick to whatever your doctor says in the lecture, okay? I'm just using this image because it's what he provided in the slide. But is this like clear?
Yes.
Okay, perfect. So the sodium is going to enter in, and it's going to make the cell more positive, or it's going to basically, in other words, depolarize the cell. Okay? Now this depolarization will cause, so when I said at the beginning that the sodium channels open, it's not only the sodium channels that open. The slow potassium channels open too, but they're called slow. So they will slowly open. So let's say at 0, okay, we have basically the -55. The sodium channels, okay, they're gonna open so fast, and the sodium is like gonna rush in. Now the potassium, it's gonna slowly open, and it will be fully open at positive 20 or positive 35 or whatever range that is at this point, or at the highest point, okay? So because it's very slow, you can see that, you see in here how like in here, the moment the sodium becomes to enter, you can see as well that the potassium is leaving. So the potassium channel will slowly open. And if you think of it, potassium is positively charged. And we have a lot of positive charge inside the cell. So the potassium, if the channel is open, it's just gonna leave because there's like a billions of positive cells in here. And you know how like you can think of it positive, repel. So it's just gonna wanna leave, okay? So the potassium will leave, and it will leave and slowly starts, so you can see because of the potassium is leaving, the positive charge is gonna slowly decrease, all right? But then, once it reaches this level, what happens is that the calcium channels will open. And those calcium channels are called the L-type calcium channels, okay? So once they open and close with slow kinetics on depolarization. So basically when we have depolarization, they're gonna open and close slowly, okay? But in here, they're going to open, and then we're gonna have, I'll show you. So we're gonna have, so we said that we have a lot, this is the outside world, and this is the inside the cell. So this is the cell, okay, in the cell. So we have here a bunch of sodium, okay, that cause the cell to depolarize or become more positive. And then, let's have a different color. Let's say potassium is yellow. So this is the potassium channel. Potassium is like literally in here, and it's gonna be like so positive, it's just wanna leave because they're gonna repel positive and positive, they can't stay, so it's gonna leave. And at the same time, the calcium channel, okay, it's gonna open. But calcium outside, okay, is more than calcium inside. So it will just going by like normal diffusion. It's gonna, you know how like in the place where it's more, it's always gonna go from like we have more calcium here. So if a gate open, it will definitely go to a place where we don't have a lot of calcium. So calcium, we have more calcium in here. So it's gonna slowly enter into the cell. And if you think of it, a potassium is going out, calcium is going in, potassium going out, calcium going in. It's like a game, plus one, minus one, plus one, minus one, plus one, minus one. So technically in here, we don't have you can see like we have a plateau where like it's just straight. The membrane potential is not fluctuating, because if you think of it, we're adding and then subtracting, adding, subtracting, adding, subtracting. And I don't know if the doctor mentioned that, but we have as well chloride, okay? Chloride entering. So it's like -1 plus 2 plus 1. Like -1 is going, I think, outside. Okay, so it's like plus. Okay, never mind this. It's gonna make it more complex. But just know that chloride is involved in it too, and the doctor mentions it later. I'll mention it whenever the doctor mentions it. Okay, so just know that for now, the calcium is going inside, potassium is going outside, and this motion is just gonna like, it's gonna be like equal, and we're not gonna have any fluctuation in the membrane potential. And this here plateau is very important. Can anyone tell me why is this plateau very important?
It's important because it makes it so that the muscle can't contract again while we have this action potential.
Perfect. That is true. Basically, this will make sure that we have a long refractory period, and the long refractory period is going to help the what is it called? Like if you think of it, the heart is going to contract, relax, contract, relax. So when it contracts, okay, if it contracts again, it's going to push more blood, but you already pushed blood. You want the blood to like think of it. If the atrium contracts, it pushed blood into the ventricle. And then if the ventricle contracts, it pushes into the vessels. So if it contracts and contracts, it's going to keep on pushing, but we want it to relax a bit or to not contract again, okay? To allow the like you know how fluent the movement is? Yeah. So it's really important to know this step because I'm pretty sure he's going to ask you about it. The refractory period is caused by what? It's basically because we have the inward movement of the calcium and the outward movement of the potassium. They're equal. So basically we're going to have like a plateau that we don't have any changes in the membrane potential. Anyways, after that, what happens is the fast potassium channel, like the fast potassium channel is gonna open, and then potassium is gonna just go all the way outside of the cell, okay? And because the potassium is positively charged and it goes out of the cell, it's going to go all the way down from, like, let's say this is positive 10 to like the normal resting membrane potential. And do you remember how in the beginning I said that the resting membrane potential is determined by the movement of potassium? So potassium, you can think of it as a it regulates the resting membrane potential. It maintains the resting membrane potential. And when after depolarization, because if you think of it, this is the depolarization. And then in here, we're having repolarization, where we're going back into the resting membrane potential. All right, is this clear?
I have a question.
Yeah, sure, go on.
What makes the potassium channels open in the first place? And what triggers it to open?
You mean at step 3 or like generally?
No, step 1. Because look, on the bottom right table, it just says sodium channels closed. It doesn't say anything about potassium, but in the graph it says that potassium is increasing.
Oh,
yeah.
I'll show you. Okay. So basically in here at 1, they just mean here. But this like it's for 2, where they say basically that the fast gate channels oh, never mind. I want to ask, did Dr. Abdul Jabbar explain it this way? Because I'm pretty sure he did. Because
Yeah, he did.
yeah, so basically just as I told you, these images are taken from books. So just follow whatever he says. I'm pretty sure maybe he added, oh, see, here he added that the potassium channels open. It's my bad because I copied this as an image. I didn't copy the text he opened, like he added. So he said at 1, the potassium channel opens, okay? So maybe the textbook he got was outdated or something, and he just added on it, okay? So
Okay.
does this make it clear?
Yeah, thank you.
Okay.
I have a question.
No.
Yeah, sure, ask.
Okay, so the refractory period, like, is it basically like when it's relaxing or contracting?
It's part of the contraction. It's not, listen, okay. The refractory period, it's just preventing the heart from going through another contraction. I'm pretty sure you guys took skeletal muscle physiology, did you?
Yeah.
Okay, so you know how basically in the skeletal muscle, sometimes the action potentials, they can merge together and they can cause the muscle to like kind of like beat like this. You get me? Like it's gonna like they call it tetani, where it's gonna be rapid contracting. So it's gonna contract more than one time.
Yeah.
So for the heart, you don't want that. So I just said relaxation as in like, not relaxation as in like the heart
So
relaxing.
it just like
but
stops for a second.
it's, yeah, you can think of it that way, but it's just that the heart does not go through another contraction again, you know? Because you don't want the heart to go like this. It's gonna it's gonna cause the blood to like kind of like flutter, okay? The blood is gonna like, it's kind of like, think of it like, okay, sorry. So this is the heart and the blood is here. If the thing like it kind of like did this, where it like contracted twice because of this, the blood is just gonna go like around and around because it's not going a full contraction where it's like pushing everything. It's just going like, it's like this, you know, like it's not a full contraction. So what happens is the blood is just gonna like like, you know, it's gonna mix the blood, and this increases the chance of forming a clot, okay? And this is
Okay.
something you don't want, so God created us in a way to prevent that. Does this answer your question? So it's not like I said relax as in like not start another contraction, but not as in like the heart stops working. It's just that imagine if it, like, you know how the heart beats, it goes like lub dub lub dub, right? So the lub, it pushes everything and it waits for a second and then relaxes, right?
Yeah, okay.
So when
Yeah.
it pushes everything, that's when like this phase where we have like the calcium gushing in. You get me? So it pushes everything and then it doesn't initiate another contraction. And then it starts to relax and then another contraction starts. You get me?
So
Is
like
this clear?
after it pushes it, does it wait for the blood to come back and then pushes it again?
Exactly. It's just because of the flow. Because you can't just
Okay.
like keep on like contracting while the blood is there. It's not gonna perform its job properly. Okay?
Okay. Yeah, thank you.
You're welcome. This slide just literally says whatever I explained in text. I'm not gonna go over it, but after that we have a wellness checkpoint where I want to know if you guys are doing okay. Am I going too fast? Is everything clear? If you have guys any questions, tell me. This is the time I can answer your questions.
I just had a question because I missed the first few minutes of the lecture,
Yeah,
which is
sure.
on me. I apologize, but
No, it's
what's
okay.
exactly the difference between a contractile cell and an autorhythmic cell?
Yeah, sure. So basically, as I told them, the pacemaker cell is the autorhythmic cell. It's the cell that generates the electricity that will cause the contractile cell to like pulse, like to contract. You get me? So the pacemaker cells, they're just there to create the electricity of the heart, and they're here, as we mentioned before. You can just like here you see the AVSA node and the bundle of His and the Purkinje Vipers. So
Yeah,
these are basically the autorhythmic cells or the pacemaker cells, and they're there just to release electricity. And this electricity is gonna, it's like the thing that stimulates the sodium channels to open, and it causes the whole cascade to.
okay, cool.
Okay, perfect. Thank
Thank
you.
you.
Any more questions? No, we can move
So
on.
I just wanted to know, like, if I understood it correct.
Yeah, sure.
So basically, when the SA node generates an impulse or electric signal, it's sent to the interconnected discs in order for the heart to contract.
No, it's sent to the, okay, I'll show you. It's sent to the muscle cell. Like this is the muscle cell, but I was at, well, what, wait. So it sends it to the muscle cell, okay? And the intercalated discs, it's just a disc that binds both cells together. So it's not just like one cell, it's like, think of it as like they're all bound together, and because they're bound together, it just helps the movement of the electricity through it. Okay, so the
Yeah.
electricity can go all the way from here to there, like in a very fluent way. It flows, and it doesn't have to like, okay, it makes only one cell contract and stop. You know how in like skeletal muscle it only causes the contraction of one thing?
Mm-hmm.
Yeah, so basically it's not like that in the cardiac muscle, and that's the difference between the cardiac muscle and the skeletal muscle. Okay, is this clear?
Yes. Yes. Thank you.
Okay, moving on. Now we're gonna talk about the refractory period. So we said that the refractory period is there. Why? It's there to prevent another contraction to happen. Okay? And we have two different things. We have the absolute refractory period, and then we have the relative refractory period. Now, remember in here when I told you that at this point, the sodium channels are going to become inactivated? Okay, so why is this keyword important? And I even like bolded it here. It's important because when the sodium channel is inactivated, no force in the world is gonna cause it to open. Okay, it's just inactivated, it's out of the world, it doesn't work anymore. It's not gonna open, it's not gonna close, it's not gonna do anything, it's inactivated. Okay, so no matter what happens, if it gets like an electrical impulse that is like super strong, it's not going to open. And because the sodium channels are inactivated, what happens is we're going to have absolute refractory period, or basically it's a period where there is no way on earth the heart is going to contract again. Okay? Is this clear? And why are we talking specifically about sodium? Because sodium is the ion that depolarizes the cell. Okay? So this steep increase or depolarization is always both by the Na, or basically by sodium. So if the sodium channel is inactivated, sodium is not going to gush in. We won't have a depolarization. So the heart is not going to contract again. Okay? And this is really important because it prevents tetanic contraction of cardiac muscle, or basically tetani, or what tetani is when like we have like multiple contractions at the same time. So basically the heart is gonna shiver, and this never happens unless like I think there is a disorder where this happens, but it's something that is totally different. But for now, just know that the sodium channels are inactivated. They're not gonna allow anything in or anything out, and we have the absolute refractory period. And the absolute refractory period is it's gonna be from here, from this point, okay, where the sodium channels no longer work, or at +20 or +35, or like just the peak point, okay, until we reach here, number 3. So from 1 to 3, like this and this, okay? In here, sodium channels are inactivated. I'm pretty sure Dr. Abdul Jabbar is gonna get a question where he's gonna be like, oh, the sodium channels are closed. Do you think we're gonna have like another contraction? And the question is gonna be like, yes, because they're closed, not inactivated. He really cares about the words, okay? So because the sodium channels are inactivated in here, we're not going to have another contraction. And if you look, it's from 0 to 200, which is literally what the absolute refractory period is. The absolute refractory period is usually 4 to 100 milliseconds, okay? So in here, we're not going to have any contraction. The heart is going to be normal. But once we reach the 200 milliseconds, or once we reach phase 3, where we're having like an increase of like a lot of potassium is leaving and so on, the sodium channels are gonna like get back to life, and they're gonna be closed, okay? So what does closed mean? Closed mean that there is a potential for them to open, okay? But inactivated means there is no way they're gonna open. So what you're trying to say here is that in the absolute refractory period, the sodium channels are inactivated. There's no way we're gonna have a what is it called? There's no way we're gonna have a contraction. But in phase 3, or at the relative refractory period, the sodium channels are gonna become at a closed state. Where, what does this closed state mean? This means that if there was an electrical impulse that was like super high, like not like -55, it's gonna be like way stronger. It's gonna be so strong it can force the heart to do another contraction, okay? But that's only if the heart is at the relative refractory period, okay? And in here, he literally says the same thing, that okay, in the absolute refractory period, the cardiac muscle cannot be tetanized. Why? Because the sodium channels are inactivated, and because they're inactivated, they're not going to allow anything. And only if basically only if the sodium channels are closed, then maybe if we have like a very, very strong electrical impulse, they might contract again. And you can see it in here, okay? So the refractory period, it's like 200, almost 250, 200, and then it's gonna start again because it's at the relative refractory period. It only can like start another contraction if it's in the relative refractory period. And in here, they're just like kind of what is it called? They compared it to the skeletal muscle. You see in the skeletal muscle how the action potential is like very, very minimal. And even if you look at the milliseconds, it's for a very short time. So because it's at a very short time and it's very fast, so what happens is it can easily tetanize. And you can see here how like there is like multiple contractions, and this multiple contraction, they're all like built up into like a very strong contraction. And this only happens in the skeletal muscles, all right? And why does this only happen in skeletal muscles? Because they have a very short refractory period, unlike the cardiac muscle. Okay? And in here, the doctor said that the heart works in a functional syncytium. And we said the functional syncytium is because of the intercalated discs. So functional syncytium means that the heart works as a whole. Like all the muscles contract together, all the muscles relax together. You get me? So yeah. Is everything clear till now? I hope they are. Do you guys have any questions? Okay, there's no chat, so I think it's okay. Can I move on? Because now we have a pop quiz. So you better like be 100% sure that you don't have any questions, so you're able to answer the question. Okay, I'll take the silence as a yes. This question, who can answer it? Can someone read it?
Me.
Okay.
The ion permeabilities and myocyte action potential are shown in the attached figure. The permeability of which ion is responsible for curve 2 in the lower panel? Should I read the options?
Yeah, sure.
Okay, potassium, calcium, chloride, sodium, and well, that's CO3.
Yeah.
I think it's B.
You think it's B? Okay, what
It's
about the rest?
because of the plateau.
Because of the plateau? Yeah, okay.
Yeah.
What about the rest?
The
You
rest,
guys all
okay,
agree?
so the potassium, I can't see the screen.
Oh, sorry, I was asking if everyone agrees it's B.
Okay.
Okay, everyone said B. Can you explain the rest?
I'll try. Okay, so for the fourth curve that we have, it's because
Yeah.
of the sodium, because like
Perfect.
a lot of sodium in there's a lot of sodium influx, so there's gonna
Sure.
be depolarization. And potassium is for like repolarization when it goes more towards the negative, so it could be curve 1, the one in gray. Yeah, and
It's curve 3.
it's
Just
curve
ignore
3.
curve. I don't know
Okay.
why he has curve 1. It's curve 3 because you see how like it opens all like the same way, or no?
Yeah, can
Yeah,
you
it is.
see?
It is curve 3 because it goes outside.
Yeah, I see.
Okay. And then,
And-
as you said, the way she answered it is right. It's calcium. And you could see it because number 2, it corresponds to the plateau. And the main thing that causes the plateau is calcium. And I guess you guys got this question in your TBL. And yeah. Do you have any question about this question?
What's curve 1?
I'll be honest with you, I don't know. Like, I have zero idea what curve 1 is. But I don't think it's any of these. Because it
Okay.
doesn't make sense, you know? Or maybe it's... I don't know. I'm not gonna tell you what it is because I really don't know. Anyways, can we move to the next question? Who wants to read this? It kind of is the same idea. So basically, the question is saying that, okay, we know that skeletal muscles, they can go like titanic contractions, but cardiac muscles tissue cannot. In comparison to skeletal muscle, what mechanism prevents cardiac muscle tissue from producing a titanic contraction?
Can I answer?
Yeah, sure.
I think it's B.
It's what?
B.
D? Why do you
B.
think that? Oh, B.
think it's
Perfect.
B.
That's correct because as we just mentioned, that the absolute refractory period is the thing that prevents the what is it called? It prevents the tetani. And we said that the absolute refractory period is due to mainly what? Can you like tell me? What is like the key word that you have to associate with the longer or like the absolute refractory period?
Due to the plateau.
Yeah, the plateau. And what does the sodium cell like? What is the sodium like gate? How is it? Is it inactivated? Is it activated? Is it closed? Is it open? Inactivated. Perfect. Okay, so is everything clear till now?
Yes.
Okay, perfect. Now we're gonna go into the actual muscle contraction and how it happens. So there's something called excitation, contraction, coupling. Oh, basically it's, you see the whole action potential that we were talking about. We're gonna see how does it reflect on the cardiac muscle. So as you can see in here, you know, before I explain this slide, I would like to explain this. So when we started, we talked about sarcomeres, okay? And a sarcomere is basically just a cell that has several parallel myofibrils, okay? This is basic anatomy or histology. I'm pretty sure you covered this before. What's important is basically to just know that, okay, the A band is, you see this dark, so we have like a dark filament here. So it's this dark filament all the way to this dark filament. And then in the middle of the A band, we have something called the H zone, which is literally this zone, okay? So this is the H zone. And then in the H zone, the center of the H zone, we have the M line, okay? I feel like it's pretty easy. This is the A band, and then this is the H zone. And then in the H zone, we have the M line, okay? And then we have something called I band. The I band is basically, it lies between the two A bands. So you see, wait, let me erase, there's a lot of lines. Okay, this is an A band, and this is another A band. The thing that is between this A band and this A band here is the I band, okay? And this I band usually contains the Z discs, or basically it's what can like kind of connects the different cells, okay? Is this clear? I'm pretty sure you guys covered this in histology or anatomy. Is it confusing? It's just literally memorization. Like, oh yeah, these dark things are the A band, and then in the middle we have the H zone. In the middle of the H zone we have the M line, and then between two A bands we have an I band that has the Z discs. Cool?
I have a question.
Yeah, sure.
So I was practicing questions and there was this question like what line or band dissects A band? And the answer was H band. And it was not M line. So I just have a question about that. Like why is it
Yeah,
why is it not
because
M?
if you think of it, the A band, what is in the middle of the A band? It's the H zone. So it kind of like it's in the middle of it. But the M line is in the middle of the H zone. Do you get what I mean? Like M line is in the middle of the H zone, but what is in the middle of the A band? It's the H zone. Does this make sense?
Yeah. So do the like words band and line actually,
Honestly, I don't know. Like, what's the point of them? I don't know. But think of it as like, okay, this is a block. What is the center of this block? It's the H zone. Okay. What is the center of the H zone? It's the M line. Cool.
Yes.
Okay. Perfect.
Okay.
Okay.
Okay. So we go in order, right?
Yeah.
Okay. Thank you.
Welcome. Okay, moving on, we're going to talk about the sarcoplasmic reticulum. That's literally like only, I think it's just more anatomy or like more just knowing the different structures, okay? So the sarcoplasmic reticulum, okay? You just have to know that we have something called a T-tubule, okay? The T-tubule is the one that is responsible of bringing the electrical impulse from the pacemaker cells. So it will bring the impulse all the way in here, okay? And then we have something called the terminal cisternae, okay? This thing here. So the sarcoplasmic reticulum, it usually contains the calcium. This is something I'm pretty sure you guys know. So sarcoplasmic reticulum equals calcium. So throughout all of this, we just have like a bunch of calcium, okay? And in here, in the, what is it called? The terminal cisternae, or the thing that is close to the T-tubule. You can think of it this way: T-tubule, terminal, both of them start in T, so they're close to each other. So the terminal cisternae is close to the T-tubule. The T-tubule is going to bring the action potential, and then the whole thing that I'm going to explain right here will happen, okay? But do you kind of understand the like anatomy of it? Like we have T-tubule here, we have the terminal cisternae that connects to this, like that is part of the sarcoplasmic reticulum that has the calcium, okay? Is this clear? If this is clear, I can move on. Like I can go back to explaining the excitation, contraction, coupling. I think it's easy, guys. It's just anatomy. Okay, I'll just take the silence as a yes. Anyways, what happens in here? The action potential will travel through the T-tubule, okay, and it will go into the terminal cisternae. In the terminal cisternae, we have something called L-type calcium channels, which is also called dihydropyridine calcium channels, okay? Those calcium channels, they're voltage gated. So once a voltage is here, they're gonna open, okay? Now, this opening, it's a calcium channel, so obviously it's gonna cause calcium to go in. But what is important, or like, it's more important, like, about this channel is that when it opens, okay, this opening is going to trigger the it's gonna like trigger the ryanodine channel, or this, the RYR. It's gonna cause it to change its shape, okay? And this change of shape will cause the sarcoplasmic reticulum. So basically, what I forgot to mention is that the ryanodine channel is like located on the sarcoplasmic reticulum. So when it changes its shape, it's gonna open. And we said, like we literally just said here, that the sarcoplasmic reticulum stores all the calcium. So it has all the calcium. So what happens is that the calcium is gonna be released, and we already have calcium that is going in. This calcium is gonna go and it's gonna bind to the, basically the myosin and the actin and cause the contraction, okay? I'm going to explain this in more details right now, but this is the idea of this slide. It's just that electricity is gonna, what is it called? Electricity is just gonna gush in. It will activate this voltage-gated calcium channel, which is the dihydropyridine receptor. This inactivation is gonna cause calcium to go in, but most importantly, it's gonna trigger the ryanodine receptor that is in the sarcoplasmic reticulum to basically change its shape. It's called conformational change. Conformational change means that it's going to change its shape. You're going to hear this a lot in MOL. So basically, conformational change means that the receptor will change its shape. It's going to cause all the calcium to go out. The calcium is going to find the actin and myosin and cause the contraction. Okay. The cross-bridging cycle is the same as the skeletal muscle. You know how like calcium has to bind to troponin C, that will cause basically tropomyosin to move and so on. And I'm going to explain this right now, but I'm just going over everything the doctor said here in the slide. He's just saying that basically the contraction is coupled to the electrical activity. So I told you that autorhythmic cells or pacemaker cells, they release the electricity, so they will cause the, basically they're going to trigger the heart to they're going to send an electrical impulse, and this electrical impulse is going to like cause the heart to contract, or the contractile muscles to contract. And this is what the sentence means. And we said that we have a lot of T-tubules. We talked about the dihydropyridine calcium channels. Now this part, I'm gonna talk about it like in the relaxation. those two slides literally just say the same thing. So in here, the doctor is just saying that, oh, the calcium is gonna go, it will bind to the troponin C, contraction will begin. He's just saying that, okay, the T-tubule, like the sentence, T-tubule membrane contains the voltage gated. So we said that, okay, here's the T-tubule, it's conducting electricity. This will open, it will cause the change for the ryanodine, which is on the sarcoplasmic reticulum. So be careful to know that the L type is on the T-tubule, but the ryanodine is on the sarcoplasmic reticulum. Cool? Do you guys have any question?
No.
Perfect. So we explained all of this. Now, let's talk about the cross-bridge cycle. To explain this, I have created a mini story that is kind of funny. Okay, so we know for the muscles to contract, we have basically an actin and a myosin. Like, okay, the myofibril is further made of actin, myosin, like they're the basic blocks. So, the story says, okay, think of it this way. So M, which is myosin, okay, he's a man. And A, she's a woman. And because we're talking about the heart, so the first thing you can think of is love. So basically, the man is in love with this woman, which is like myosin is in love with actin. And he wants to like propose to her. And other important thing to know is that P and ADP in my story are like the father and mother of the man, and tropomyosin and troponin are like the father and mother of like actin. Okay, so M is with his family, A is with her family, and they're really in love and they want to like get engaged or whatever. So what happens is that basically M wants to like get engaged to A, but tropomyosin and troponin, which is basically, or tropomyosin, and it has troponin, they're basically standing in M's way, and they're like, oh no, you can't have our daughter. You don't have enough money, so we're not gonna like let you get engaged to her. Okay? And then what happens is myosin is gonna wait and like try to get money. And money in the story is literally calcium. So once he has calcium, so basically when the electrical impulse comes and calcium is released, the myosin is gonna just take all this calcium, which is basically the money, okay? And this is like, think of the calcium spark as like the moment he gets all the money, okay? We have a lot of calcium, oh, he has a lot of money. So he's gonna give the money to basically, wait, I wanna see this photo, okay. This is a better photo. So this is actin, okay, which is the female in the story, and this is M, which is basically the male. ADP and P are the parents of myosin, and they're like, okay, you don't have enough money, don't go like propose. And then this is tropomyosin and troponin. This is tropomyosin and this is troponin, and they're like the mother and father of like actin. They're like holding her back. And then once calcium or money comes into the story, let's say myosin gives basically the parents the money, and they're like, okay, here's your money. Can we get engaged? And then they actually do get engaged because, okay, so the myosin and the actin are like finally together. And because they're together, but they're not yet like fully together, like they're still engaged, okay? So they're kind of together. So the myosin is still at the 90 degrees, not the 45. And then when they want to get married, so M is not going to live with his mother and father anymore, or like phosphated ADP. So they're going to leave, okay? And once like his mother and his father leave, and basically once ADP and P leave, they can get married. And then once they're married, their love is going to become more powerful, or we're going to have like the power stroke, okay? And at the power stroke, this is when basically the myosin, it's usually at a 90 degrees, it will change to 95 degree, to 45 degrees. And this is gonna make like, oh, their love more powerful, okay? So they're gonna cause a contraction. Because if you think of it, love equals heart, and heart contracts. So when their love is more powerful, the heart's gonna contract, okay? I'm sorry if it's like cringe, but like, I don't know, I feel like it's a way you can remember this. Anyways, so when the heart is contracting and the myosin is at the 45 degrees, okay, this is what we call the rigor state, okay? And this is when the heart is contracting, it's pushing all the blood and everything. And then ATP comes into the story, and ATP, you can think of it as like the home wrecker. It will come and it's gonna separate myosin from actin again, and it's gonna cause like the attachment. So myosin is gonna be detached from actin, and then like they're going through a breakup. Then we're gonna have the relaxation, okay? Because once ATP is there, the head is gonna go back into the myosin. The myosin is gonna go back to 90. It's no longer going to be with the actin, and it's going to move. Think of it that way: to move the myosin head from like 45 degrees to 90. It needs energy. So when ATP comes, it does that. So it does that. So to relax the muscle, we need ATP. So once the ATP comes, it's gonna leave and they're gonna relax. And then you know how like if we break down ATP, we're gonna have ADP and phosphate. Do you know what an ATP is? Like molecular way. So basically ATP, it means that we have basically 3 phosphates, okay? And ADP, because it's like, I don't know what does it exactly stand for, but the T in here means triple.
Yeah, it's adenosine triphosphate and adenosine diphosphate, and then monophosphate.
Exactly.
Yeah.
Exactly. So the ATP is triple phosphates. ADP is double phosphate. So basically, to break down ATP into ADP, 1 phosphate leaves, and that's how basically that's how you you use the energy. So for the myosin head to use this energy, it's gonna break down the ATP and it causes the relaxation. Okay, is this clear? Now let's go back to
Yes.
scientific like terms and explain it in a scientific term. So basically, the myosin, it's gonna have so at the 90 position, it's gonna have a phosphate and an ADP. And then when calcium come, okay, calcium's gonna come, it's gonna bind to troponin C. It's important to know that it's troponin C because troponin has like, you see here, like we have troponin I, troponin T. Just know that troponin is gonna bind to troponin C. And once it binds to troponin C, the tropomyosin is going to like flip the actin. The actin's gonna bind to the myosin. And then once it binds to the myosin and the ADP leaves, you see how like phosphate leaves and ADP will leave too. We're gonna have the power stroke where we go from like 90 degrees to 45 degrees, okay? And then this is what's gonna cause the contraction, okay? And then after the contraction is over, if ATP joins, like if ATP comes, it's going to, the myosin will bind, like ATP, think of it this way, we have the myosin. The myosin has somewhere for ATP to join, okay? So when it does that, it will use its energy and we're gonna have ADP and phosphate, okay? Now, unless myosin binds to actin, with the help of calcium, obviously, ADP and phosphate are going to live here, okay? So once myosin binds to actin, ADP and phosphate, they leave. So this area here, it stays empty. So if there is ATP, if energy is available, ATP will directly bind here. Like no matter what, it's just gonna bind there, okay? So once ATP binds, the head's gonna go back into the 90 degrees, the 90 degree position, and it's gonna detach. Okay, and in here, those 2 slides, they talk about the same thing. They're just like, okay, calcium binds to troponin C, and then it causes tropomyosin to flip the actin and to like the side where it binds to myosin. It's gonna bind to myosin. We're gonna have the powerful stroke, and this power stroke is gonna cause the contraction, and then the ADP and then the ATP will come and it will like kind of just like let them break up. Okay, is this clear?
Yes.
Was the story too cringe?
No, it was not.
Okay. Anyways, so basically to relax, so we talked about like contraction and everything. Now for the relaxation, what happens is that we need to remove the calcium, because if calcium is there, contraction is there. Just always like think of calcium and contraction together. Okay, so we want the thing to relax. So what happens is we have something called we have calcium ATPase. Okay, calcium ATPase, it's basically a channel that works by ATP. We need energy to cause it to open, and once it opens, it will push the calcium outside. Okay, and not outside, like inside where? Back into the basically sarcoplasmic reticulum. You can see it here. You see how there's an ATP and how is there movement of calcium. So basically this is calcium ATPase, where basically the once ATP binds here, it will cause the calcium to go from in here, because if you think of it, during contraction, okay, during contraction, we're gonna have a lot of calcium here. So once it opens, okay, the calcium is gonna gush back into the, what is it called? They're gonna gush back into here, okay? And basically we have another thing that is the sodium calcium exchanger. So basically we're gonna have like, I don't know why it's not drawn here, but let's say we're gonna have something called sodium calcium. So what does this mean? Exchanger. So it exchanges one calcium. So one calcium in equals one potassium outside. Okay, and this I think works without energy. Yeah. So now calsequestern. Okay, so now think of it. Okay, all of the calcium is going back into the sarcoplasmic reticulum. But if you think of it, let's say we have 50% of calcium here, and then 50% of, no, wait, this is stupid. Sorry. Let's say we have like 80% of calcium here and 20% of calcium here. How do we make sure that, and the channel here is still open, okay? How do we make sure that calcium does not leave the sarcoplasmic reticulum down its concentration gradient? So we have something called calsequestern, and if you think of it, sequestern, or like it kind of like sequesters or like holds everything. So it's like a protein which binds to calcium inside the sarcoplasmic reticulum, and it makes sure that the calcium stays inside the sarcoplasmic reticulum and it does not leave the sarcoplasmic reticulum. So that's like, if you're wondering, oh, like, okay, we're gonna have a lot of calcium, so it eventually has to flow out. But no, because of calsequestern, it's not gonna flow out, and it's gonna be stored inside the what is it called? The what was it called? Sarcoplasmic reticulum. Okay. That's all for the slide. And then the doctor in here is talking about ATP. So I know that you guys got a TBL question that was very confusing, and I actually added it here. It's this part where the doctor asked ATP was used for which of the following, and I don't know, what did you guys put? Can you tell me what did you put in the TBL? Can you can someone read the chat? Like, Razi, can you read the chat?
Yeah, so they are saying C.
Oh, so all of you put C? Or did some of you put A?
Some says A.
Okay. So this is where the confusion comes in. People are saying, oh, but like, and I understand this confusion because in here, in this slide of ATP, the doctor says, I'll show you. Is it here or is it on another slide? I think it's, okay. In here, the doctor says the dihydropyridine channels, they need ATP, okay? They need ATP for normal functioning. And then if we have decrease in ATP, the dihydropyridine channels are not gonna open, and then we're not gonna have a contraction. And I know this sentence makes it sound like ATP is important for contraction. And I want someone who chose A to tell me, oh yeah, this is the reason I put A, or to just explain why did you choose A? Is this the reason why you chose A? Am I confusing you guys? I'm just asking because when I read the slides, I kind of understood why the doctor put the right question, like the right answer as relaxation, not contraction. But I want to make sure that this is the point that made you guys choose A. Is it?
The right answer was contraction, not relaxation.
Was it?
Yeah.
No, it's C. It's not A.
Yeah, I put C, but it was the right answer
Oh,
is A.
yeah, it was A. Okay. So, yeah, but I want to like, did he explain it this way? Did he talk about the dihydroprotein channels?
He talked about why it was not relaxation, because when the ATP bind to the myosin, the myosin actin filaments, it wasn't really relaxation, it was just like the change in conformation.
Oh, it does make sense. Okay. So let's go back to this and then I'll explain why. So in here, we said that the ATP, like the doctor is just going over the same things. That okay, ATP binds to it binds to myosin, it causes the myosin to detach from the actin, and then we're not gonna have a power stroke anymore, we're not gonna have a rigor crossbridge, and so on. Okay. And he says that basically the ATPase of myosin is going to hydrolyze ATP to ADP and PI, and then it's going to go back to the 90 degrees orientation. And I think all of this it makes sense, right? Yeah, I think it does make sense. Anyways. So, does it make sense now? I think, yeah. Okay. And then in here, the doctor is talking about what affects cardiac contractility, okay? We know that calcium is the main thing that affects the cardiac contractility. And basically, if we want to increase the contractility, we increase the amount of calcium that we have, okay? So basically, if I have like twice the amount of calcium, I'm going to have like twice the what is it called? The contractility, and it's going to be more strong. So it's really important to know that that calcium concentration actually affects the cardiac contractility. Okay? And I think it's pretty clear, right? Like we kept on saying how calcium is the thing that causes contractility. Just know that basically cardiac, the contractility of the heart depends on the calcium concentration. If we have increased calcium concentration, it's going to cause basically the heart to basically beat faster. So that's why, yeah, because you know why, right? Okay, I'll take the silence as a yes. And then in here, the doctor says that the DHP channel needs ATP for normal functioning. And because the DHP channel needs the ATP for normal functioning, if we don't have ATP, then we're not going to have any contraction. Because in cases where, let's say, a patient is admitted because, okay, so let's say a patient travels or like climbs Mount Everest, okay? You know how as we go at a higher altitude, the oxygen levels decrease. So if the patient is like kind of exerting so much energy, like using energy for like, let's say climbing, and he's already at a place where we don't have a lot of oxygen, he's gonna go, he might suffer from myocardial ischemia, where basically the heart is not getting enough oxygen because, as I said, the air does not have enough oxygen, and is not getting enough ATP because, let's say, the person who was like kind of like climbing Mount Everest did not eat, did not do anything, and he's using his energy for like manual work. So let's say his ATP is depleted and his oxygen is low. this might increase the risk of having myocardial ischemia, or basically the myocardial ischemia means that a tissue that no longer has oxygen and ATP. So it doesn't have energy, it doesn't have oxygen. So when this happens, what happens is that the dihydropyridine channels are not going to work because the ATP is not going to bind to it. And that's why, if you think of it, if the ATP does not bind to the dihydropyridine channels, if we don't have this influx of calcium, if we don't trigger the ryanodine receptor to open and release all the calcium from the sarcoplasmic reticulum, then there's no way a contraction will happen. So even if we have ATP inside, like in here, okay, like, let's see, the ATP in here, even if we have ATP at like beside the myosin and the actin, if this step here was not initiated, if this step where we have basically ATP, like if the dihydropyridine channel did not open because of ATP, okay, and because obviously we said it's voltage gated, so it needs the voltage, but to work as a normal channel, it needs the ATP. So if we don't have ATP here, even if we have ATP in here, it's not gonna be like, it's not gonna work. The contraction is not gonna happen. So if you think of it this way, this will answer the question of, oh, why ATP is more important for muscle contraction than muscle relaxation. You get me? I think that's what Dr. Abdul Jabbar was trying to get at, but I would understand why you might think muscle relaxation, because even the ATPase of the calcium needs ATP. Anyways, just follow whatever Dr. Abdul Jabbar mentioned. But did you understand my way of like telling you why ATP in contraction is more important? Because if there's no ATP there, then nothing's gonna even happen. It's not gonna start. So it's actually more important to initiate the contraction rather than to stop it. Is this clear? Or did I confuse you? Guys, be honest with me. Wait, I want to check the chats. Is it clear? No one's answering. Does it mean that both are technically correct? Yeah, like honestly, listen, if it was me who was solving, I would have been confused because both of them, it is true, like here the ATPs require ATP, but if you think of it in a way that it's all or none, like if you think of it, if we don't have ATP at all, the contraction is not going to happen, so we're not going to need the relaxation. So it's kind of more important for the contraction. Do you get my point? It's not like a rule of choose what happens first, but yeah, like think of it that way. That's like the only way I could like think of why ATP is just only for contraction. But yeah. Anyways, do you guys have any question up until now? I'm literally in the last slide, but I just want to make sure that everything's okay. You can just type in the chat because I can see the chat right now. Okay, let's go back to this. Yeah, we're literally at the last slide, so we're just gonna say that okay, what other things affect the contractility? So number one, it's the ATP supply. If we don't have enough ATP, we're not gonna have contraction. So it's gonna have negative inotropic effect. That's an important word to know. Inotropic means contractility. So if it's a negative inotropic effect, so we're gonna have decreased contractility. But if it's a positive inotropic effect, that's like increased contractility. Okay. Now another thing that affects myocardial contractility is acidosis. What does acidosis mean? Acidosis means we have a lot of acidic anions. What are the acidic anions? We have like mainly The most important one is hydrogen. Whenever you see a hydrogen ion, just know that there is acidosis. Like think of acidosis if it's like more than usual, but like hydrogen is usually like an acidic thing. Like just associate hydrogen with acid, okay? So if we have increased hydrogen in the bloodstream, okay, then we're gonna have like acidosis, okay? And this acidosis increases, okay, when we have ischemia. You see how we say here myocardial ischemia, decrease in oxygen and ATP. So basically, when we have ischemia or decreased oxygen and ATP, we tend to have an increase in hydrogen or hydrogen ion or acidosis. So think of it as, okay, if we have ischemia, we're gonna have acidosis or increased plasma hydrogen ion. So this is gonna cause to basically decrease the myocardial contractibility. So acidosis and myocardial ischemia or decreased ATP and oxygen are kind of like interconnected. Okay. Now, another thing that affects basically the myocardial contractility, but in an opposite way, in a positive inotropic effect, where it increases contractility, is basically when, let's say, a person has heart failure and he's admitted to the hospital. Usually, the first thing they give him is something, it's a drug called digitalis, okay? So what is digitalis? Digitalis is a drug that prevents sodium and potassium ATPase from working. Okay, so if this ATPase is basically the calcium ATPase, okay? So if this ATPase, like you remember this ATPase, where is that? Yeah, you remember this ATPase, if this ATPase is not working, then what's gonna happen? Calcium is gonna be here. So calcium is gonna stay longer with the actin and myosin. So this is going to increase the contractibility, okay? So think of it that way. We have sodium and calcium exchanger. They usually remove the calcium by getting activated by sodium and potassium ATPase. Okay, so they're connected. So I'll tell you how they're connected. You see here, this one, we have two channels, okay? One that is Na plus K plus ATPase. So this channel is, and then in here we have Na plus K plus exchanger, okay? The exchanger does not need energy to work, but it needs it needs a difference in the gradient. So we have to have more calcium here than here to basically move. So what happens is the ATP will bind here, and what will it do? It will cause the sodium to increase inside, okay, and the potassium to leave. So sodium will increase inside and the potassium is going to leave. And then because we have a lot of sodium inside, okay, and we have calcium outside, it's going to exchange the sodium that is inside, okay, with so the sodium is inside. This is the cell, okay? The sodium that is inside will be exchanged for a calcium, and that's how we let all the calcium in. Okay, do you get it? Is this clear? Or is it confusing? I can re-explain it. But it's kind of like, it kind of makes sense because look, like this is a wall, and we have here Na plus K plus ATPase, and because it's called ATPase, this means it needs ATP to work. Na calcium exchanger, right? So if we have Na a lot inside and potassium a lot outside, and then we have here we have a lot of calcium, here we have a lot of Na. So Na is going to be exchanged to calcium. So we're going to have a lot of calcium here. So this is how like relaxation happens. Is this clear? Do you guys have any question about this? Okay, I'm assuming you guys don't have any question. Or I'll check the chat in a bit. So basically, by inhibiting the ATPase, so we're not gonna have sodium in or potassium out. So the sodium and the calcium exchanger, they're not gonna work. and then we're gonna have more calcium with the actin and myosin, so we're gonna have more contraction. Okay? And this sentence here,
I have
yeah,
a question.
sure.
So when the inhibition of Na and K, like it results in calcium accumulation, but like what does that do?
So that calcium accumulation will cause the contraction to last longer. We're gonna have more like we're gonna have more calcium, and it's gonna stay with the troponin C. So because it binds to troponin C, it will expose the actin. Actin and myosin are going to like stay together, so they're gonna contract for a longer while. You get me?
Okay, so like what's the main reason for like the longer contraction? Is it
The
calcium?
availability. Yeah.
Yeah.
So basically, the availability of calcium is what causes the longer, like you get me? It causes
Yeah.
the positive inotropic effect. Like we're gonna have an excess of calcium, so all of the cells are going to contract. You get me?
Yes, okay.
Okay, and in here, the something similar to it, something like for the protein phospholamban. Okay, it usually inhibits calcium ATPase. So if it's phosphorylated, okay, it will no longer inhibit it, and it will cause the ATPase activity to increase. Okay, so sometimes proteins need to be phosphorylated to either be active or inactive. You're gonna take this in one. So if a protein is inactivated by phosphorylation, so it's not gonna work, okay? So phospholamban, it's basically a protein that binds to calcium ATPase, or like the whole thing that I just explained, okay? So if it binds to the ATPase, it usually binds to the ATPase and prevent it from working. So when it prevents it from working, it's kind of doing the same thing the drug does, where it increases the calcium, and we're gonna have a positive inotropic effect, or we're gonna have increased contractility, okay? But if the phospholamban is phosphorylated, it's gonna inhibit this protein. So this protein is not gonna work. So if you think of it, usually it inhibits the calcium ATPase from working. But if we inhibit the inhibitor, or we inhibit this protein, and it's no longer affecting the ATPase is going to work faster, and then this will cause increased relaxation because the calcium is going into the ATPase and so on. You get me? Those are important things to know because the doctor likes to ask like specific details. So you can expect a question about digitalis or about phospholamban, or about ischemia. Okay. Now a mini pop quiz. Who wants to answer this? Okay, I'm sorry, I removed it. I just want to see the chat. Okay. Does anyone want to answer this? They're the last two questions and we're done. I'm sorry to take so much of your time, but it's like, it needs a lot of explaining this lecture. So what do you think, guys, is the answer? It's like a true or false. Okay, so is it true that the muscle action potential, it goes from the sarcolemma down to the transverse tubules? Say true or false. I can't see the chat. It's true. Okay, so you kind of guys answered the question because everything else is just false. And in here, it's the question that we talked about, the muscle contraction. And I still believe both of them are correct, but if Dr. Abdul Jabbar says contraction, then it's contraction. And it kind of like, okay, it does make sense. Like contraction comes at the beginning. So if we don't have ATP, then it's not going to happen at all, you know? But that's all. Thank you guys for attending. And if you have any questions, here's my phone number, here's my email. you can contact me and I can send you the what is it called, the slides, but I didn't really add much, but I can send them anyways. And if you guys wanna like ask me any questions, feel free to text me or send me an email. I do prefer text because it's easier to just like respond on WhatsApp. And if you ever see me like and wanna ask me face to face to explain anything, I'm like more than happy to do that. That's all. If you guys have any questions for now, you might answer. Okay, I'll stop sharing. Okay.